Okay, so our next presentation is going to be given by Dr. Andre Capp. And just to introduce Dr. Capp, who unfortunately the U.S. military doesn't allow him to use Zoom, so I think he's going to phone in, and I'll run his slides for him. So Dr. Capp earned his bachelor's degree cum laude from Harvard and a master's in science and then in technology and policy from MIT. And then he's worked in management and policy consulting before he went to medical school at Boston University. He has an MD and also a PhD in pathology. Andre completed his internal medicine residency and his hematology oncology fellowship at Walter Reed Army Medical Center, and has been working with the U.S. military, I think, since that time. He's currently the director of research for the U.S. Army Institute of Surgical Research, where he runs a very large operation. That's about 350 staff there, and a very large budget, helping the DoD spend its money. So Dr. Capp has been very active in looking at the introduction of novel blood components and similar sorts of products, and is, I think, well known to those of us who work with colleagues who are focused in military medicine. So Andre, I am going to share your slide.
Thanks for that, Dana, and I apologize for the technical limitations here.
No, that's okay. That's okay.
In a year of virtual meetings with folks, it's been a real challenge because we're not allowed to use Zoom. So yeah, it's anyway.
Yeah, let me just get your slides up. Okay,
yep.
Here we go. Okay, so you can just tell me I'm on your title slide, so you just tell me when you want me to switch.
Right. Okay, great. So, the title there is Transfusion and Beyond, Transformational Change in Massive Hemorrhage. And what I hope to walk you through is, Dana had asked me to speak a little bit about what's new on the horizon for military medical research and transfusion medicine. And so I'm going to tell you. And hopefully it will give you some perspectives on where we're going to spend some DoD money in the future. All right, next slide. So these are my disclaimers and disclosures. Full-time active duty officer in the U.S. Army, don't really have any material conflicts of interest. Next slide. So, we definitely are very interested in transfusion medicine in the military. Because as you can all guess, when we study the cause of death of soldiers and on the battlefield and frankly anybody in a war zone, the big cause of potentially survivable death is bleeding. So you have lots of non-survivable injuries, but of the things that are theoretically survivable, it's bleeding is the big thing, and clearly, transfusion medicine might have something to offer in that area. So next slide. And in fact, the sort of obvious things to do when faced with bleeding trauma patients is to get them to surgery as soon as possible, control the bleeding and give them transfusions to keep them alive. And in fact, in Afghanistan, the Secretary of Defense at the time, Robert Gates, issued a mandate that we would have enough helicopters in the country to make sure that patients could get to a surgical treatment facility within an hour of injury. And when we implemented that, as published in this analysis of the impact of that decision here in JAMA Surgery, we found that we had lower than predicted mortality. And that's sort of that undercurve there based on compared to the trend line. That you see on that graph. And then subsequent analyses of that data showed us that the biggest single factor in reducing trauma mortality on the battlefield associated with this so-called golden hour policy was pre-hospital transfusion. Next slide. And additional analyses of this one published in JAMA by Stacy Shackelford and colleagues showed that receiving pre-hospital transfusion definitely lowered 24 and 30-day mortality quite significantly. Next slide. And the interesting thing is that transfusion timing is really everything. And patients who received transfusion within 15 minutes of medevac arrival, which on average was 36 minutes from point of injury, derived a tremendous benefit from transfusion, whereas those who received transfusions later did not receive the same benefit, as you can see here. That's not to say that no transfusion beyond this time frame was of value. It's just that from the standpoint of did it add much to pre-hospital resuscitation, giving it late did not add much. In other words, those patients were either going to survive anyway or had died already. So you really have a narrow window, and you got to get blood into the patient fast. Next slide, please. So while all these analyses were being done, and there were many other papers published in this area, all kind of pointing in the same direction, we spent a lot of time working on blood products, as Dana mentioned, to facilitate this early resuscitation of bleeding patients. And it developed a paradigm with some of our NATO colleagues, including our good friends in Canada, as well as Norway and France and the UK and others, of remote damage control resuscitation. And the idea is basically give blood and give it early. And the most convenient way we found of giving kind of all of the functionality of the lost patient blood was through whole blood, and in particular low titer O whole blood, which could be used on any bleeding patient. But just to highlight the point that all the data I just showed you from the golden hour analyses and Stacy Shackelford's paper, most of those patients received component therapy. So really any mix of components was superior to no resuscitation or to receiving clear fluids, which we've known since at least the 1980s. And really, I mean, even before that, there were reports of how crystalloids caused worsening bleeding dating back to World War I. So we've kind of always known that crystalloids were not really the thing for bleeding patients, but we allowed sort of wishful thinking to get in the way of experience and physiology. But anyways, blood components or whole blood delivered expeditiously was the way to keep patients alive. And one of the things you see pictured here, in addition to the low titer whole blood, is the 4-degree platelets there. You can see the little 4C. Is another product that we introduced in the course of this recent conflict. And those cold platelets are also contained in the cold stored whole blood. So this talk is not about cold stored platelets, but I did just want to highlight that one point. So next slide, please. So the U.S. Army 75th Ranger Regiment was really the first to implement as an entire unit this sort of RDCR concept, and they called their program the ROLO program, Ranger O Low Titer, because the foundational blood product for their program was low titer O whole blood. But it includes key elements of hemorrhage control. You see a tourniquet pictured there. Use of tranexamic acid as close to the point of injury as possible. I mean, immediately. In fact, they use tranexamic acid to flush the intraosseous device that they place immediately on the casualty or the IV. So that's the first thing that goes into the patient. Whole blood uses of plasma as well, in particular as freeze-dried plasma, as a bridge to whole blood or as a whole blood extender. They don't carry clear fluids. And they have also started giving calcium gluconate with the blood products to avoid critical hypocalcemia. And you see an early version, the published version of their algorithm for treating the patient. All this happens at the point of injury, even before the helicopter gets here. So that's kind of the state of the art at the tip of the spear, if you will. And that's where 20 years of painstaking quality improvement research and retrospective analyses of trauma registries, animal studies, in vitro studies to support various development efforts and so on have gotten us as kind of a state of the art, if you will. So next slide, please. So the bottom line is, there you go. Start transfusion even before you're loading the patient into the helicopter. Control bleeding, give blood, get to surgery fast. And I'll just show you, next slide, please. With complete air superiority, as in Afghanistan, what this really amounts to is kind of bringing a lot of hospital-based interventions to the patient. So here's a little vignette about a real patient, a member of the Ranger Regiment, actually, who sustained 2 AK-47 gunshot wounds to the chest at night on the side of a mountain in the wintertime, terrible conditions. Honestly, that's usually a fatal injury, no matter where you get shot, but certainly under those conditions, it sounds pretty bad. Next slide, please. So this is the kind of damage that kind of wound pattern does. It's really a devastating injury. In this particular case, it caused a pulmonary artery transection, 2.5-liter blood loss as hemothoraces, shock, coagulopathy, and hypothermia. So it sounds bad. Next slide. But 1 month later, he was discharged from Walter Reed and actually returned to active duty in the Ranger Regiment. So how did that happen? Well, so first of all, you're starting with a really healthy young man here who's in the best shape of his life. But in addition to that, lots of things were done. Again, kind of what you would see in a level 1 trauma center trauma bay was brought to the patient. So, chest seals, needle decompression, tranexamic acid, freeze-dried plasma, blood on the helicopter, hypothermia prevention kit, multiple points of vascular access. There was a 6-person surgical team waiting very close by with some additional assets. So they were able to intervene pretty quickly, figure out that the patient needed a thoracotomy right away, did it right there in the back of the helicopter, fixed the pulmonary artery injury, did cardiac massage, put some more blood into him, got him back, and then that was really kind of the main surgery, and everything else after that was, ICU care. And he did great. Next slide, please. So, that's kind of the culmination of 20 years of progress in military medicine and in trauma care. And that's had definite impacts throughout the world in civilian trauma medicine. And I think we've gotten better at our game. But if you're reading the newspapers, you know that the name of the game in the future is, transition away from these counterinsurgency type operations to, potential peer or near peer conflict. And the Army, the U.S. Army is calling this multi-domain operations and large-scale combat operations. So what does multi-domain mean? It means kind of the whole spectrum of operations: cyber, space, air, land, sea. It's really complicated, and all of those things have implications for medical care. So next slide. So, there's changing adversaries in the battlefield. Medical challenges are going to change. We had low casualty densities. That vignette I shared with you was, 1 patient and a huge amount of resources devoted to one patient. Whereas if you're dealing with adversaries who have weapon systems like what's pictured on the right, you might have a much higher casualty density and, for a bunch of reasons, longer evacuation times. And so it changes both what you can bring to bear on the patient in terms of resources, as well as wounding patterns, casualty density, and all those things. Next slide, please. So a little bit more on the MDO concept here, this multi-domain operations. So I kind of like to call it Star Wars meets Stalingrad. So, you think back to like huge challenges of World War II, but with much more accurate, devastating weapons. And again, things like cyber operations. I mean, we depend on computers for everything like medical record keeping, logistics, command and control, communications, the whole thing. If those get disrupted, chaos reigns, as you know, when your EMR goes down. Long-range precision fires are a big deal because essentially, if you have drones that can kind of surreptitiously fly around the battlefield and present targeting information to, at very low risk to people far away with weapon systems that can hit you at 200-300 kilometers out, or even 1,000 miles out in some cases, you really have a problem with force concentration, logistics hubs, hospitals, all those things would become vulnerable in a way they never have been before. Aerial defenses mean, you can't fly helicopters to where they need to go. And then, if you're in a dense urban environment, that presents a whole bunch of other challenges. The bottom line is that, mandating a 60-minute evacuation time with blood on the helicopters is really not going to be possible. So so this sets up what we call prolonged field care. What are you going to do in the pre-hospital environment for a long period of time? Next slide. So the other way to think about this is that we've made all these gains of battlefield care, unprecedented, survival from these devastating injuries, and it all comes down to rapid access to blood and surgery, and and hemorrhage control. So, if you're not going to be able to provide those things, you need something else. Next slide. And when you really think about it, I mean, I alluded to this earlier, but care in trauma medicine has been pretty, progress has been pretty incremental and slow. Imhotep, the Egyptian physician and architect, describes in a document that is about 5,000 years old, the use of bandages and splints and poultices to help with bleeding control. I mean, it sounds like kind of combat gauze. The fundamental technology of like a gauze bandage with stuff on it to help stop bleeding is 5,000-year-old technology. I mean, now it's sterile, which is nice, but still tourniquets, at least 200 BC written evidence of tourniquet use. Blood transfusion at the front lines, RDCR, 1918. Freeze-dried plasma, a big new initiative, developed in the 1930s, 10 million plus units fielded in World War II. Here's a soldier getting transfused plasma on the beaches on Omaha Beach in 1944. And even tranexamic acid was developed in 1966. But granted, we didn't learn how to use it in trauma until 2010, but still, with the CRASH 2 trial. But it's not new. And low titer whole blood pictured up in the upper right. World War II also. So next slide. So what we need is some transformational progress that takes us a little bit beyond these, tried and true, but, technologies that we may not be able to deliver in the kind of time frame that they're needed. And so I think, it's time to really put our thinking caps on and try to move beyond, use the advances in biology and physics and chemistry that have enabled things like moving from a dial phone to an iPhone, or a chest X-ray to functional MRI, or nitrogen mustard. There's mechlorethamine up there. World War II era chemotherapy, and now we have CAR T cells. Let's see if we can use some advanced biology to change things in trauma medicine. So next slide. Bottom line is we can't keep doing what we've been doing for 100 years. We need innovation. And so next slide. The real challenge is to keep tissue viable and preferably not infected, to allow functional recovery, hopefully while controlling pain and keeping soldiers in the fight. But you can think of that for the civilian world of, enabling survival and functional recovery. So next slide. So this really makes us focus our research planning on fundamental biology challenges. What is it that's actually killing patients at the cellular level following injury that we could potentially target now that we have a better understanding of cellular metabolism than we did, say, in World War II, in order to, advance a little bit beyond where we have been. So Army Futures Command, which is my parent command, is the part of the U.S. Army that's in charge of like modernizing the entire thing, and new helicopters, tanks, communication networks, the whole thing. And they have 6 big initiatives for the future. And so at the ISR here in San Antonio, we spent fair amount of time thinking about how we might model our medical research planning on, in a similar way, really focus on some fundamental challenges, and not just, we didn't come up with 6 things just because, our parent command did that, but we tried to really limit the focus, because going after hard problems in pathophysiology requires a lot of resources and it requires time. And if you spread yourself too thin, then you don't get anywhere. So we came up with 5+1. And, I talked about the golden hour from Secretary Gates. My boss, General Murray, who's the commander of Futures Command, said, yeah, I need more than an hour. How about a golden day? Now, a golden day is a hard one, but we're shooting for extending viability times beyond an hour, or even if you look at Stacy Shackelford's data, like 30 to 40 minutes. Next slide. So we thought hard about what are the things killing patients in the immediate time frame, that first 24 hours. And we kind of broke this down into, 5 major problems plus one a problem here. We have the House of the Golden Days, sort of a concept, and you've got 5 pillars holding it up, and you've got a lintel at the top. My daughter is an architect, my oldest daughter, so she wants me to use the right terms. So it's a lintel. Um, and anyway, so the first thing obviously that happens, everything derives from cellular hypoxia. So putting blood back in the patient is certainly an important thing. So transfusion medicine doesn't go away, and we have some initiatives in cell preservation that I think are going to continue to be important. But if you can't get enough blood to the patient, what can you do at the cellular level to resuscitate shock, preserve mitochondrial function for when you reoxygenate, and so forth? And it turns out that we've made a lot of progress in this area. For example, if you think of the recent Nobel Prize winning work in the regulation of the HIF-1 alpha pathway, there are multiple druggable targets in that pathway that can help adapt the body to hypoxia, even in a very short time window, such as post-trauma. You don't necessarily need to adapt somebody to life on Mount Everest over the course of months with these drugs, but even in a very short time window, they have an effect on helping to clear lactate and reorient metabolism in a helpful way. So that's just an example. There are other drugs in development that directly target dysfunction of mitochondrial electron transport chain complexes following hypoxia, and that really help mitigate ischemia reperfusion injury, at least in early models. So this is the kind of work that we envisage in that pillar. The hemorrhage and vascular dysfunction piece, in a manner kind of similar to blood-based resuscitation, hemorrhage control, and the various mechanical approaches to doing that, I think are still going to be important, such as figuring out how best to implement endovascular approaches like REBOA. But really, the response to hypoxia at the vascular level is change in endothelial phenotype, sort of popularly known as endotheliopathy in the trauma research community, and that kicks off a whole bunch of problems. Fibrinolysis at first, thrombosis later, edema formation. Edema formation, of course, causes multiple second hits to tissues. Think about brain injury and then followed by brain edema, even just hypoxic brain injury followed by brain edema as a potentially lethal second hit. So getting after that vascular dysfunction and trying to mitigate it through modulation of various signaling pathways is I think a critical node of pathophysiologic failure that leads to death that we can bring some modern biology to. If you get the patient through that immediate post-injury period, they often have damage to multiple organ systems and require organ system support. So we've got great extracorporeal life support systems available in ICUs. There's been a lot of work done to miniaturize those and make them usable in pre-hospital settings and in transport settings. Big challenge here is thrombosis, both in the circuit and at the microvascular level in the body. And so safer antithrombotics that can be used to support patients on ECLS, sort of a critical area that needs to be solved. And frankly, venous thrombosis events are a major, lethal event post-injury anyhow. And so if we can do better in that area, I think that would be good. The combat wound care pillar really speaks to infection prevention. And, a single dose of systemic antibiotics that may or may not get to disrupted tissue, hasn't worked super well. We need to move beyond that, incorporate local therapies and emerging pathogen agnostic systems that will prevent wound colonization and biofilm formation. So this is an area of very active work. And in particular for burn patients, I think this is something that shows a lot of promise. Pain control is really a huge issue on the battlefield. We don't do a good job of it as it is. We don't do a good job of it in the civilian world in the immediate post-trauma setting. And the physiologic demands of suffering pain are significant and need to be mitigated. So there's a lot of work to be done there. And then the engineering piece you see at the top is really enabling technologies that help in all of these different areas. Things like decision support systems, informed possibly by AI, as well as physical engineering systems like RIBOA for hemorrhage control and other things. So this is kind of how we're organizing ourselves and thinking about kind of the fundamental biological problems that we need to solve if we're going to move beyond the basic technologies that we've had for a very long time. So next slide. So this goes into it a little bit more, and you can see kind of flip the pillars on their sides, and you go sequentially over time, like what are the things that are happening. Acutely you get hypoxia, then you get mitochondrial failure, there's this endotheliopathy, vascular leak, et cetera, and then you've ultimately lead to compartment syndromes, tissue necrosis, et cetera. Some of these things overlap. They're all, they're not meant to be stovepiped, but they sort of are linked problems, but really it gets down to how do you die, and is there a way to kind of slow that down and prevent it by extending technologies that already work. So again, not a replacement for transfusions, but I would say adjuncts that could improve the efficacy of transfusions or sort of stretch them out. Next slide. So here we've kind of gone to actual products or capabilities fielded, with those in red being sort of what we call our kind of moonshot projects, real breakthroughs that would dramatically improve care of the injured patient. And the ones in black are kind of, more incremental changes to things that are already fielded. Our mandate is to get to battlefield improvements by 2035. That's our kind of long-term goal. If you go to the next slide, in 2028, we have sort of a halfway point, if you will, kind of waypoint, where we can kind of take stock and see what's moving forward and so forth. And so we've got kind of interim goals as well, where we're trying to make sure that we get some of these things fielded. And then finally, last slide, I mean, this is a little bit, moonshot-ish in the sense that the problems we're trying to tackle and develop solutions to really are quite difficult. On the other hand, the payoff is a big deal. So, we recognize that across these 6 domains, we may not succeed in all of them. But, if you keep in mind the fact that the fundamental technologies available for treating injured patients up to surgical care, initial surgical care, haven't really changed conceptually in quite some time, success in any one of these domains would actually be a pretty transformative change. All, of course, building on a solid backbone of transfusion medicine. So I'm sorry for the very brief whirlwind through that, but I hope it gives you a sense of where we're going and where our investment will be over the next decade or so. I'm happy to take any questions.
That was great, Andre. Thanks very much. I think that just for this audience, because it's pretty non-military, I think one of the really important take-homes for us is that these kinds of developments that occur in military medicine show up, 5 or 10 years later in civilian medicine, and I think that's a really important thing to consider. That some of the strategies we have for applying the golden hour technology are now here with us for civilian medicine as well.
Yeah, absolutely.
Dave Farrell has a question.
Hi, yeah, what things are on the horizon to prevent edema? That's an area that we've been quite concerned with in our research. Are there any potential drugs that you could foresee or are in development in that arena?
So there are some products that seem to reduce edema formation compared with historic treatments. But I will say that I think there's a lot more basic biology that needs to be done here to improve on the list of options available for clinical testing. So certainly moving away from crystalloid resuscitation to plasma unequivocally reduces edema formation. We had a learned society called something like, the Society for the Study of Abdominal Compartment Syndrome, which was born of the resuscitative efforts common in the 1980s and 1990s, where your typical surgical ICU had a dozen patients with open abdomens and terrible gut edema and really high mortality. And when we stopped using high volume crystalloid resuscitation, that completely went away. Like, I can't even tell you the last abdominal compartment syndrome patient that I've heard of in our surgical ICU. And so, that just, I think speaks to some very useful changes. So plasma is part of that, but you still have problems of compartment syndrome in other places. You have problems of brain edema following hypoxic injury. So what can we do there? Tranexamic acid actually has some anti-edema formation ability. How we use it best is unclear, whether it's a dosing thing or whether it's really just part of the solution. Plasmin activity definitely has an effect on activating vascular leak through a number of pathways, to include bradykinin. So the potential for bradykinin signaling blockade plus tranexamic acid to prevent plasmin formation in the first place, has some promise. And in our animal models, it's not as exciting as we hoped it would be. Bradykinin seems to mediate brain edema and any sort of above the neck kind of activity, but not anywhere else in the body. So something else is needed. Ultimately, I think the angiopoietin 1 and 2 signaling pathways, the Thai receptors and kinases associated with that downstream, may present some useful druggable targets. And I know there are compounds in development in that area, but I think there's still more work to be done here. Platelets obviously play a role in reducing edema, and if there may be even synthetic platelet options that, or we'll say engineered platelets that may specifically have activity in this area that can be enhanced. So I think there are a lot of different angles to pursue. This is one of the hardest problems to solve, I think.
Thank you.
Yeah, thanks, Andre. Okay, we're getting a little tight on time, so maybe let's take Massimo. And I know that the rest of you guys know Andre, so you can email him. Okay,
Yep, happy
Massimo,
to talk by email.
Hi, Andre. Thanks for the great talk. I'm wondering what you see as the state of technologies for hemorrhage control, particularly in abdominal hemorrhage. I'm talking about Ruboa and these tourniquets, potentially moving toward these future scenarios with long evacuation times and long wait times to surgery and prolonged field care.
Well, the big challenge is distal ischemia and then subsequent ischemia reperfusion injury when you release the RIBOA. Intermittent RIBOA seems to partially deal with this, but I'll tell you, one of the biggest challenges we've had, Ed Mazikowski, who heads up our DoD pathology, forensic pathology service, has really taken a deeper dive into what sorts of theoretically survivable major vascular injuries really are survivable. And a recent analysis that I believe is now finally out in print suggests that actually very little of this is survivable. So, a vascular surgeon looks at it and says, yeah, I can repair an iliac artery injury. Yeah, except they bleed to death so fast that nobody actually makes it to a surgeon is the problem. And so when we really do that deeper dive into our data set, it's not clear that there are enough casualties who are likely to benefit from any of these technologies like RIBOA that it will justify the incredible challenge of training pre-hospital providers and maintaining their skills in this area. Certainly our special operations forces are kind of early adopters and they've looked into this. And what they've found is they don't use it a whole heck of a lot for all of these reasons. So it's tough. It's tough. I think the abdominal tourniquet kind of thing, again, is, if you've ever had one of those things on, that is a very short-term solution. I was a guinea pig for testing that. And you can barely breathe. So, I think endovascular approaches are probably one of the few things that could be useful in this area. I think probably more work in this area is needed. I know the counterflow technology that's being developed up there, Christian Kastrup and colleagues, doing great work. Perhaps that will add another tool that will help quite a bit. So all under evaluation, and we're interested in hearing ideas in this area. Over.
Thank you.
Great. Thanks very much, Andre.